Hello, everyone. Thank you very much for coming to this talk, this virtual talk on avoiding and managing complications in facial aesthetics. I would like to take this time to thank the Canadian Board of Aesthetic Medicine for having me part of faculty and being able to impart some knowledge for you guys. And hopefully you can embrace key aspects of this presentation. And if you have any questions, I'll be happy to answer them at the end of this presentation. So without further ado, let's make a start. So what we're going to be talking about is have an overview of the different types of complications. We'll talk through how we would manage certain complications. Again, this is more of an overview and a quick insight. And I'm sure we'll have other talks throughout the day as well, which might be a little bit more specific on what we do. And given the 15-minute time frame I have, I am quite passionate about patient safety and complication management. So it will be a generic overview, and I will address a few things like needle versus cannula, aspirating, talking about higher versus lower risk areas. And before we do move on to questions, there is also a case scenario as well. So as you can see, just from the image here alone, that anatomy is pretty much everything, and then the technique is it follows that. So this is your worst case scenario, where I'm sure you'll agree you can see obvious skin necrosis and you can see ophthalmoplegia, and blindness. So the main thing here is this is rare. However, we should be able to stop the patient from getting to this stage. And we're all very good as practitioners saying to patients after injectable treatments, don't drink alcohol, don't exercise, keep the area clean and so forth. But we should be also remind patients of safety netting advice. For example, if you're experiencing any skin breakdown or color changes or any visual disturbance or anything that's out of the ordinary like pain, then this is something that we should be portraying to them to get in touch, and then we can maybe intervene at that point in time to try and prevent this. And this would essentially be your worst case scenario. The PAMP safety rules, so I'm just going to get all four right out here. I'm not going to say them in any particular order, but essentially what you need to do even before you treat or touch the patient is pre-assess them almost, and almost like have a plan in your mind. So first of all, you need to have the right patient. Somebody who's got jowls that are coming down, to their knees, are they exactly going to be the right patient? They've got protruding eye bags, are they going to be the right patient? So find the right patient. And once you have the right patient, then you've got the other factors to consider. What product are you going to use? And then how much of this product are you going to use? 0.5 ml, 1 ml, 10 ml, and what method? The methodology or the actual treatment planning. Is it needle? Is it cannula? Is it a layering technique? And so forth. So once you can pre-assess the patient, and then you can prime them for what you are about to do, and you're always thinking one treatment ahead. And I guess this falls under the same category of pre-treatment screening, which is also your consultation. And the consultation involves your medical history, trying to fish out, are they clinic hoppers? Is there an element of body dysmorphia or OCD? Have they had anything done recently? If so, who, by, and how long ago was it? And why are they here? And the rest of the medical history, which goes without saying, is equally as important. So product selection, we want something that is long-acting, biodegradable. There's very little migration, and it's not harmful to the human body as well. So a few things that you need to think about regarding product selection as well. So coming on to classification of complications. Now there's two particular types. The first type here is what we would call acute. And this is something like hypersensitivity, anaphylaxis, an embolism occurring, which can lead to ischemia, which then eventually leads to necrosis, and things like infection, swelling, asymmetry. These things you're going to usually pick up whilst the patient, it tends to be there in your clinic. And so we can classify these as an acute type of complication. And then we've got our chronic complications, which can be like delayed onset nodules or granulomas, which are classified as chronic. So this is your first basic type of classification system. And then you've got, a second type of classification system. It would include trauma, nervous complications, lymphatic complications, infective, inflammatory, and vascular. And discoloration, I guess, will also be of its own kind too. And let's go through each one of these individually. So trauma, what can you have trauma? Well, you can have bruising or hematomas. You may have swelling as well there and then at the time of treatment. And given you're going to be using needles and cannulas, there's very likely to be post-treatment or post-injection erythema, especially in the area that you've been injecting. So these things can be normal. From a nervous point of view, we're looking at pain. We're looking at, is there any sensory loss? Is there any muscular loss or facial palsy, sorry? Is there an element of neuropraxia, which is temporary nerve damage? So these are things that can occur. And usually neuropraxia is probably the most common one here, along with pain, both of which are usually self-limiting. So not much that you need to do other than just reassure and handhold the patient. And obviously knowing the anatomy, but some things in injectables are a little bit more tricky. For example, when doing PDO threads, as an example, in the lower third of the face, it's usually quite easy to sometimes irritate a small branch of a larger nerve. Lymphatic complications. Now, a classic one here would be the tear troughs. So somebody who is prone to swelling, or somebody who you've done the treatment of, and you've not gone deep enough into the soup. So maybe you're a little bit more superficial. And this is a compartment where the lymphatic drainage isn't as good. And this can then typically lead to something called malar edema, which would typically happen about 2 weeks post-treatment. Again, you don't really need to do anything. It is self-limiting. Otherwise, things like hyalase or diuretics can also be of use, with the other options on this probably being a little bit more invasive, like surgical stenting. Infection can also occur as well. So this is something that we need to just keep in mind that it's not always going to be our fault. It could be due to post-treatment advice not being adhered to, and it comes in various forms. It could be a boil or an abscess, which may require incision and drainage. It could be cellulitis, which will then require antibiotics. Biofilms are going to be hard to diagnose, given this is almost like a sterile film of bacteria over the product, and again, usually is more of a chronic complication. And something like cold sores and herpes can also occur. So various things for us to consider here. And again, different trusts and different hospitals and different practices will have slightly different protocols. Infection control, always keep, the things as sterile as possible. And I guess, this should be basically, grilled into us from day one of doing aesthetic treatments. Immune or inflammatory complications. So this will include things like hypersensitivity, autoimmune responses. For example, you might have global edema of the face, you might have angioedema. Anaphylaxis is another example. And again, there would be very specific protocols for these things too. Something like swelling or some mild hypersensitivity, you may want to consider antihistamines and steroids too. And given it's an immune response by the body to a foreign body that has been placed in, you may also want to consider removal of the foreign body as well, once symptoms have calmed down. Vascular problems, this is probably the most exciting one. So a few signs and symptoms: pain, usually out of proportion, pallor, so paleness, purpura and pustules, ischemia, necrosis. And these things are usually not the first instance. Okay, so when you normally have a vascular compromise situation, there's certain things that you're going to be looking for in the first stage. And if those are missed, then we will, start seeing other signs, for example, pustules and purpura and a skin breakdown and further discoloration. This tends to be the second stage. However, there are certain things we can do to pick up and try and prevent vascular compromise from becoming necrosis. So non-HA fillers, I'm not too sure how big this is in North America. However, usually the main complication with them tends to be nodules. And the best way to try and sort these out would be intralesional saline, intralesional steroids. Sodium thiosulfate can also be used as well, depending on what filler exactly was used. For the most part, I like to think most of us do use hyaluronic acid for the purpose that it can easily be reversed. Emergency toolkit. So what should be in your toolkit? Hyaluronidase. You know, this is malpractice essentially. You know, if something goes wrong and you don't have the antidote for it, then you know you will be held accountable for this. So hyaluronidase is very important. Aspirin is also important for reasons I will talk to you about later on. Topical GTN, very controversial. Usually not something that I personally tend to use. Will it cause any further harm or damage? Probably not. But my preference is to use a systemic vasodilator, like sildenafil. Antibiotics are probably not going to be kept there and then in your emergency kit, likewise with the steroids, but there is something that you know you should have easy access to. Antihistamines, warm compress, obviously won't be warm in your kit, will it? And you know, it's a little bit more overkill, I guess, but a bacterial culture kit. But probably the most important thing, having pre-arranged phone numbers for emergency referrals. Now let's talk about the vascular occlusion. So there have been studies on this, quite a lot of studies actually, and what we see in the literature is literally the tip of the iceberg. There's so much that is not reported out there, which is quite scary actually, because it just makes, you know, you start doubting yourself and you start double checking, am I doing things right? Am I looking out for the right things? Because it is a fact. There's a lot more out there that is not reported. So how do they occur? So I'm going to try and use this tree as a classic example. So this could be a main arterial branch, and then you've got all these smaller branches, and then you've got different parts of the skin. Now, if you add the filler into the main branch, because of hypertension, this will move distally, and then it can take any route it wishes. It could go this way, this way, this way, or it could even go this way. And let's say it's took the first exit, so it will come all the way over here, and then it will dislodge here, and this arteriole is essentially supplying this part of the skin. So this is where you're going to see skin color changes, because there's not enough oxygenation and blood flow to the skin. Whereas the skin adjacent to this, you might have very normal skin. So, and this is what we would call mottling. So skin color changes, a bit like patchy bruising, is what we call livido reticularis, which is a classic picture. So extravascular versus intravascular. So there was a study in 2016 that, you know, did conclude that extravascular compression could not cause vascular necrosis of the skin. And if you think about this logically, if there were signs and symptoms of a vascular compromise, of some firm heat and massage, you would like to think that this is going to, you know, even out the area, reduce the pressure or the compression on the vessel, and therefore there's now back to normal reperfusion. However, you know, it hasn't been reported. So, you know, what we do know is that when it's an intravascular, that's when things will go wrong. So this is what we need to keep in mind, that if there is a vascular compromise situation, you know, you can never say anything 100% in medicine. However, there's a very, very high percentage, probably very close to that 100, that there's going to be an embolism. Okay, there's a filler embolism. And there is no such thing as compartment syndrome in the face, a bit like in the arms and in the legs. So, you know, this is basically important to know, because we know that the hyalase isn't just going to be locked into this one compartment. It's very potent and it will spread like fire. And I guess that is a good thing. And because there's no compartments in the face per se, we've got various layers. You know, it's even more difficult then to try and have some form of compression occlusion or extravascular occlusion. Now, in certain parts of the face, it might be a little bit more probable, for example, in the tip of the nose, where you might experience a bit of blanching. However, again, it's not going to outright go ahead and cause necrosis. However, never say never. And I guess this is another diagram, which essentially, let's say you've got, this is your external carotid, and this is your facial artery, and you are injecting in to the junction between the facial artery and the angular artery here. Now, as you have pressure on the plunger, the filler does not move distally. It actually moves proximally up until the point you let go of your thumb from the plunger. So as soon as there's no pressure on the plunger, then hypertension is going to cause the filler now to move distally again. So let's say the filler got up to here, you let go of the plunger, it's now going to go back down the facial artery, or it may go down the superficial temporal artery, which then is part, as we know, is part of the external carotid system. This is then going to link with the internal carotid system, and this could cause visual disturbance. Okay, so this is exactly the physics behind how a VO will occur. Now, if you look at this image, a very, very nice image, and I remember I said earlier on that we should have aspirin in our emergency kits. Now here with the black arrow, this is your dermal filler. Nice clear gel right into the intravascular. The D over here stands for the distal end. What do you think we have here? So normally you have blood flow in this direction and it can't pass the filler. So you have stagnant blood. This therefore becomes a blood clot, and this is your embolism. So what good is dissolving this filler here when without aspirin, this embolism will then just dislodge and possibly cause signs of a stroke or a palsy. So this is why aspirin is very important. Now, lovely colleague Katie and friends and colleagues have done this study, and this was back in 2015, just to highlight the cases of blindness in particular. I believe there were 98, and you can see where all the higher risk parts of the face are, including the glabella, the nose, and the nasal labial fold. And the study was then repeated 4 years later in 2019, and there were a further 48 cases. And again, the distribution still seems to be along the midline of the face. So what are the clinical features of a VO or a vascular occlusion? So blanching, usually the first sign, blanching, pallor, paleness, and usually it doesn't last too long. Pain is another sign that you will find early on. And it could be due to the vascular spasm, lack of blood flow, but pain usually is going to be out of proportion. And there's going to be color changes. There's going to be something like a bruise might turn up. It might remain pale. It might go into spreading erythema. There's going to be some form of color changes that is not in keeping with an uneventful treatment. And remember, a bit like a stroke, you know, you have a stroke, you've got the area where there's a stroke, the area around it, I believe, going back to my medical school days, is called like the penumbra. And this is an area of ischemia which can be reversed. But then even further out, you'll have parts that you cannot reverse. And this is, what we call necrosis. So ischemia can be reversed, not necrosis. So keep that in mind. And most important thing is recognition. You know, if you can diagnose there's a compromised vascular situation, then we can always try and take care of these things, and the sooner the better. The antidote, as you know, is hyaluronidase, also known as Hyalase in a shortened term. And there's various treatment protocols, and this is one of the high dose protocols, which you'll see, and you can see basically progression of the filler being dissolved until you get normal reperfusion again. And this is what it's called, the new high dose pulse hyaluronidase protocol. And essentially what they're saying is using high doses of hyaluronidase into the affected tissue, not necessarily where the filler is sitting, in terms of, sorry, I will rephrase that, not necessarily where the filler was injected, but more so where you are seeing the tissues being affected. So the skin color changes, the pallor, the erythema, the mottling, the patchy bruising, the livido reticularis. This is where you're going to be using the high dose oxygen, hyaluronidase injections. What are the higher versus lower risk areas? So a nice diagram here actually, and you can see what we would classify as the, the 5 or 6 high risk areas. For example, the glabellar region, the temples, the nose, the forehead, periorbital and nasolabial fold. And surprisingly, one of the first things that I usually taught, typically anyway, on a foundation course is nasolabial treatment. And this is a very dangerous area to be injecting, especially if you don't know the changes in the anatomy from the inferior to the superior part of this region. Needle versus cannula, and I guess this all depends on personal preference and your sound knowledge of the anatomy in the area that you're injecting. So, I, for example, I'm a needle guy. I pretend to use a needle in most parts of the face, but I like to use a 25 gauge cannula for tear troughs. Occasionally, I will use a cannula to define the angle of the jaw, and occasionally I might use cannula in the mid-face or the temples for more superficial layering. However, I'm a big fan of bolus injections onto periosteum with a high G prime product, which is just my style of injecting. But just because you use one over the other doesn't mean you're safe. And I will hear a lot of colleagues that say that a cannula is safer and you won't have a complication. Well, actually, you can have a complication from anything. And what makes you safe is your anatomy and knowing the depth of your injections. And that goes without saying. And a good injector will pick one of these things and run with it. And the best injectors will be able to use both and keep them both in their toolkit. To aspirate or not aspirate, there's a huge thing, I think, all over social media, around the world, essentially, do you or do you not? And there was a study that was done which basically did 340 individual aspiration tests. And you can see the statistics on the screen in front of you. And there were 112 true positive aspirations within the first second. And you can see positive results between 1 and 10 seconds was seen in 101. So, is it as effective as it is probably made out to be? And the answer is no. And I always say, if you are only relying on aspiration as your safety net, you run into a problem at one point in time. We should be relying on other signs, not just aspiration. The pain response from the patient, surrounding color changes, looking at the skin, and then just looking if there's any other signs and symptoms, blanching, pallor, livido, bruising, hematoma, anything. We always have our eyes on the skin, essentially, not the syringe. And this is how things can go wrong. And blindness can also occur, as Katie and colleagues have shown this. And, there's 4 subtypes, if you like, of periocular complications associated with blindness. I'm not going to run through them all, but, it is graded out there. And, without trying to put this or sugarcoat this, if your patient has blurry vision and there is no visual perception of light coming through, it's a very, very, low possibility that you are going to be able to do anything with that, unfortunately. And, like I said, I'm not going to, sugarcoat that for you. Retrobulbar injections, some people are probably injecting away carelessly, I guess, and, thinking, oh, there's always going to be solutions like retrobulbar injections. But first of all, are we all trained to do this? No. And it does require an extreme amount of skill to be in the right place and to make sure you're not going to be doing more damage than harm. And there needs to be more on this in the literature regarding, should we be doing them or should we not? And finding the right ophthalmologist or eye specialist that will be able to do something like this. Keeping in mind that, a very small study was done on rabbits, actually, and we can see that in most of the 8 pairs of eyes that were used, in 6 of them, there was no improvement. So again, your chances are quite low. in terms of reversing something like that. Prevention is always better than cure. And how do we prevent things? Simple, know your anatomy. Know about the external carotid system and the internal carotid system, knowing where the anastomoses are likely to be, and appreciate anatomical variations. For example, let's say the supply of the lip, the superior labial artery and the inferior labial artery. Sometimes there is no superior labial artery. So we really do need to appreciate anatomy. Nothing is textbook. And the one most important thing is the depth of your needle. Always appreciate that as well. So let's have a look at a quick case study before we bring this presentation to a close. So we've got a patient who is an 18-year-old, no past medical history, otherwise fit and well, wants filler for the first time in her lips. You can see her lips here in front of you on the screen, and was done by an experienced colleague using a needle. Immediately post-treatment, this is what she looked like. Now, some of you might say a bit of swelling going on. Is there a bit of filler migration? Is there too much filler on one side? What's going on? Some of you might pick on a few things. Those of you that have a keen eye for detail might not just be looking at what's going on the lip, but might also see a bit of redness here. If you can see a bit of erythema here, and even on the lateral aspect of the nostril. There's a very particular reason why I took this image. So, you're thinking she's had her lips done and you're looking at her lips, but if you look very carefully, there are subtle signs, but let's see if you pick that up or not. So, what do we see there? Does it look normal? Does it look like a bruise or a hematoma, swelling? Does it look like there's a vascular problem? So 2 days later, because this went amiss, and this is what the patient presented like. So you can see, the nose was not touched, but what we have is a very clear vascular compromise situation. She was in this excruciating pain. I can assure you that the capillary refill was down to about 4 seconds in the lip area and very sluggish in this nasal labial fold region too, as well as the lateral aspect of the alar. So what do we have essentially? So is it an infection? Is it a vascular problem? And I guess the main thing that you can do there and then is, one, is physically lay fingers on the patient and assess for the reperfusion time, which is known as the capillary refill time, and try and ensure this is less than 2 seconds. As I said, in this case, it was around 4 seconds. It was very sluggish. And the pain score, asking the patient out of 10, how bad is the pain? Is it 2 out of 10? Or is it an 8 or a 9 out of 10? And I think it was quite high up for this patient as well, compared with what it was like on the day of treatment. You can see, given that it has been 2 days now since this was picked up by myself, you can see that there's now blisters and pustules forming as well, which is part of the normal sequelae of having a vascular occlusion. So just highlighting and summarizing things here again for you: pain out of proportion, there's skin color changes, and you can see little pustules and papules forming too. So what are the management? What's going to be the management? It's essentially hot compress. You're going to give her the aspirin there and then 300 milligrams. Again, your protocol may slightly vary over there in North America. And we're going to use the antidote, which is hyaluronidase. And we want to consider prophylactic antibiotics and some steroids. I am in the process of writing a paper, and I guess there is also a bit of a debate of whether we use a tapering dose of steroids, or do we just use a standard dose for a short course of a few days. In terms of the hyalase as well, I would just like to say that, the way I would manage this complication is I tend to use anywhere between 500 and 1,000, usually around 600. If you want a number from me, that's what I tend to use. Around 600 units of hyalase, and I tend to use a cannula. And the reason why I don't use a needle is purely because by penetrating the skin multiple times with a needle, I'm going to be causing a lot of bruising. So when I review the patient the following day, the bruising may be masking the underlying livedo reticularis, or the mottling. Therefore, I like to use a nice part of the skin which is unaffected, use a 25 gauge cannula subdermally, and I tend to use 600 units of hyalase. My dilution of ILAs is in 5 ml. So I get a 5 ml syringe full of saline, and then I put 1 ml of saline into the hyaluronidase, and then I draw this back up into this 5 ml syringe. Therefore, each ml is 300 units, and I would use 2 mls, which is 600 units, with a 25 gauge cannula subdermally in areas of concern, which would be, I would have entered here, quite lateral, and I would have fanned this whole area, including this region here near the alar, and again, another entry point in the lip here, and then fan the cannula all the way across. Now, there's nothing wrong with doing it with the needle, but this was my preferred technique. And as you can see, everything has worked out in the end. Brilliant. Thank you very much. And I will be more than happy to take any questions.